Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Siegel, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
You can also subscribe to us on Patreon for on-demand content for injectable and business education. Now, for full disclosure, this is take 2 of this evening's podcast. We had some technical hitches in the Gold Coast, but I think we are sorted now.
We are back.
How are you, David?
I'm good. It's a Monday. I feel out of sorts because we normally don't record on Mondays. It's normally Wednesday. So, yes. But anyway, here we are. Sync
up with the famous Dr. Mobin's diary. We've been trying to do this for about 8 months now, and we are finally here. We're all got free time.
How are you guys? Good to see you.
We are very good. You were last on the podcast. Have a guess what episode you're on. We're now on 290
something. I had a bit of I could check. Yeah. What do you do now?
This will be about 291.
Oh, wow.
It's been a few.
How many years do you think it is?
Six and a bit now.
Since last podcast?
No. So you came on episode 93. So that would have been probably year 2.
Yeah.
So yeah, about 4 years. Anyway, it's nice to have you. And for our listeners who haven't met you, you actually did a lockdown webinar with us as well. That was your first appearance with us. And we were one of the first people to talk about aesthetic ultrasound. That was kind of quite new back then. But in this podcast, we're going to relook at, where are we with all this kind of stuff? Why should we be using ultrasound? Should everyone be learning, or are we still recommending that only experts do it? What's the point of MRIs? How long do fillers last? And this is all your research. You've done some papers that you've published and delve into all of that. But tell the listeners who you are and your background and how did you get into this?
Well, I'm Mobin Master Radiologist is my main game, which I started in 2003 as a registrar. I've been a consultant for many years now, over a decade, 13, 14 years or something, maybe longer, actually. And I started doing aesthetics approximately 7 years, maybe 7 to 8 years ago. It was through a friend of mine, Goran Gurkovsky, who's got more degrees than a thermostat. He's done physio. Now he's just finished nursing. He's got a master's in sonography, so he's an ultrasound gun. And his main work was varicose veins. He also owns a skin clinic. Oh, and I forgot, he's got a diploma in skin as well.
Right.
So that too. So he does lasers, etc. too. So he started doing a lot of varicose veins, and I was reporting for him privately, which I still do. And then he encouraged me to go, why don't you go to injectables? And I said no for many years, actually. He was telling me for many years. And then I thought, all right, I'll start it. And so I started dabbling, as people say, like a bit of Botox, absolutely petrified of filler. I did not do filler for about 7, almost 12 months after I started. I just started with tox. Yep. And then I began doing filler because I was absolutely petrified. And being a specialist, we're scaredy cats. And then I got some requests when I started, injecting over a period of time to look at an MR and get a double read, just have a look at it, because I had an understanding of filler and its behavior and what it looks like on MR, whereas the average radiologist doesn't have the first idea. And I double read one that was one of Gavin Chan's patients, and it was post-septal under the globe. And then he said, well, why don't you dissolve it under ultrasound? You know how to use ultrasound, don't you? And I was like, I got a sinking feeling in my stomach, and I go, yeah, I guess you're right there. I don't have much of an excuse. So we did it. And that was pretty much one of the first cases I ever used under ultrasound and Hyalase under the globe, within millimeters of the globe. And the look on Goran's face was priceless. Priceless. He was looking at me going,
And had that been documented elsewhere? I mean, I gather people like Leone and the Dutch guys maybe were, doing this before you, but did you learn from them, or was this completely independent?
No, completely independent. So the post-septal filler, for example, I described it for the first time, 3 cases, and published that in PRS to describe the actual phenomenon of post-septal filler and how easy it is to actually do. Yeah. And there was 3 cases which were successfully dissolved. The first one, however, she wasn't completely satisfied, and I think her expectations were very high, so she ended up going to surgery.
Right. What does post-septal filler mean? We're for people that aren't sort of up to speed with their facial anatomy, which hopefully they all are, but I'm sure maybe there's some newbies out there that don't know what we're talking about. Where is that?
There is a fibrous septum that actually is between the front of the eye and then the back of the eye in the intraconal area. And if you perforate that septum, which can be quite delicate in older patients, if you penetrate that, it'll go under the globe. And if you want to dissolve it, there is no way you can get rid of it if you just inject around the orbital area. You have to go under the globe and penetrate that septum and squirt Hyalase literally under the eyeball.
Basically, it's a little barrier under your eye that normally retains a bit of fat. So people with those big eye bags that you can see,
right,
that's where the septum has been stretched and the fat is bulging from under the eye outwards. And so what Mobin's saying is it's like a wall, and you've got to put your needle through the wall under the eyeball to get to this filler that's in the wrong place.
Gosh, and does the patient manage that okay? Like, how do you do?
It's quite, Jake, we did one remotely together, and you asked me the questions and asked me what we should do. I was in the middle of procedures or something like that, so I couldn't video call you live, but you managed. How did your patient feel? Mine are very comfortable.
Well, let's get into that a little bit later. Let's save the punchline. Well, it's not really a punchline, but I'd want to get into complication stuff a bit later. But let's, I guess, orientate our listeners, because some people would have dabbled with ultrasound, some haven't, some have decided it's not for them, it's too tricky, difficult, expensive, whatever. But we've had ultrasound roughly for about 4 years now here in Australia. Now, other countries took off a bit earlier, and then we had COVID that sort of delayed things in Australia. We were supposed to do a course in 2020 and it didn't happen. So what's your take on, ultrasound in aesthetics? Because some people are still not sure, and I don't really know where we go from here, because it's quite hard to scale that teaching.
Look, there's quite a few courses going on, and there is teaching going on, but I think the teaching, which unfortunately I don't have the time for, I feel needs to be simplified. You're going through 10 layers and identifying under ultrasound 10 layers in the temple. Or you can know about the 10 layers of the temple, but you identify the layers that are most important. The fascial layer, the deep fat, the superficial fat, the 2 layers of the superficial temporal fat, subcutaneous fat, skin, right? I think from my point of view, I like to simplify things, and you'll find that specialists, when they do a lot of teaching, I teach a lot in a public hospital and probably had 50, 60, 70 graduates that I've worked with teaching them radiology and ultrasound, etc. I think simplifying it makes it easier, because some of these courses and some people just get too overwhelmed. I don't know whether you feel the same way. I think it can be overwhelming because you're trying to delve into way too much detail all in one go. And therefore a lot of people I've heard just simply give up, or just sits there and they don't use it because they're like, too hard, right? So I think simplifying it and then starting with certain things that are basic that you can do practically. For example, inject under ultrasound, be taught how to do just chin augmentation under ultrasound. Just that. Just start with that. Keep it simple. Just do that. Needle here, the probe here, your needle sort of longitudinal. Find the vessels, put your color on and inject slowly. VOs, for example, they can be quite daunting as well. And people, again, I even find them difficult, but I always get the bottom of the barrel where people have tried already and then it's really difficult. But I think it's a little bit underdeveloped at the moment, and there's a lot of people out there who bought a scanner and it ends up just sitting idle, which is a shame.
Yeah. Well, what's your observation of people that you've been mentoring and speaking to, David?
I think everyone appreciates that there's utility and they're a great safety tool. I know a lot of people that use them for basic parameters. So, temporal, like high risk areas, they're scanning first. So like piriform fossa, if they're doing temples, they locate temporal artery. That's kind of where I think most of the uses are coming from. I don't have any clients that have used it for an emergency situation, but I don't think many people would have the confidence to even attempt it under an emergency because they're not experienced with it enough to feel comfortable. Like it might be something they haven't had enough experience doing to trust themselves in that situation. So I think everyone likes the idea. I just don't know whether enough people have the basic skills to be able to use it. I don't think it's an equipment thing. I think it's an education thing. Yeah, I think a lot of people are scared by it, I think, as well.
Yeah, I mean, look, there's a couple of companies who are, of course, providing the devices, and they're trying to do as much as they can for support. I just don't know how it can be scaled and take people past that basic sort of, here's how you turn the scanner on, and this is what the grey stuff means. Moving past that, I think's what's harder to teach people. You can go abroad and go to some of the courses, but they're very expensive and, difficult to get to, and you've got to pay for a flight. So that information still feels a bit ring-fenced to me. So I think you should start a course, Mobin. You need to help us.
In my spare time.
Yeah, exactly. In the time that you don't have.
I was going to say, part of the limitation is the technology is just so foreign to people. They don't know what they're looking at. I mean, do you think in the future there might be a sort of a great leap forward in the technology itself that is specifically designed for aesthetic injectors, where it becomes just almost idiot-proof? You what you're looking at becomes simplified. I don't even know what that would look like, but it feels like everything that we do in aesthetics has kind of just been re-engineered to work for our industry. Nothing's been designed for our industry, really. Not even the needles that we inject toxins with are designed for injecting toxin.
Yeah, it's funny. I shared an image with Mobin the other day from LinkedIn, and maybe this is more practical for hospital, but it was like, you describe it, Mobin. I don't even have to describe it. You're the radiologist.
Well, I think it was a CT hybrid ultrasound.
Yeah.
It's basically a hybrid technology that overlays the CT scan on the brain, and then you're using a scanner. I don't think that was an ultrasound. I can't remember what they were using, but the same technology. You can't ultrasound a skull because you can't get through it. But let's just say a liver, which I saw in the US when I was working at USC, you get a scan of the liver under CT or MRI, and then it has to be a specific scan. It gets loaded onto this ultrasound scanner. The ultrasound scanner has actually got 2 detectors on it, on the probe. And then when you've loaded it on, the exact location where you're scanning over the liver, you've got an overlay on the ultrasound of slices or a 3D of the actual CT of the liver with color codes.
And this is the patient underneath the scan. So you're actually doing a live CT.
You can actually see the liver, like the anatomy, like it's a live anatomical, almost cadaverical surgical structure. And then you can see a needle go in because it's overlaying that image. But it's extremely costly and it's extremely fiddly. So when I did see it, I'm like, well, this is great, but it's just not something you can just throw on. It would be amazing if you could do that.
Well, the reason I sent you, because I thought, well, wow, can you imagine seeing a face like this?
Yeah, it'd be awesome.
Sort of
face on 3D, you just do an MR and then you turn that into an ultrasound image, and then you've got the 3D and you can see the blob of filler or what have you.
Yeah.
But not practical yet. The problem as well is, and it's just almost contradictory, us radiologists in the public hospital have to have less than 10-year-old scanners for Medicare to be used, right? To be swiped. And we've got leases with these big companies. The big companies lease $120,000 scanners, ridiculous quality scanners. So everything looks 1,000 times better than these portable handheld ones. So the double-edged sword is that the injectors obviously are not going to spend that kind of money, and then they're given a scanner that is harder to interpret than what a radiologist has to interpret.
Well, I guess the point of that is it's got to be scalable and affordable, but also if you don't know what incredible quality is, you just learn from, the basic quality. And so you kind of don't know any different. Maybe for your level, that's
because
you're seeing both.
I scanned a face at the hospital, and I just looked at it. I'm like, oh my God, life would be so much easier if I had this scanner in my clinic. But I'm not going to spend $120K on a clinical scanner that I use once a week.
Yeah, I mean, what does a scanner cost these days? I mean, for a portable one that has practical use in the clinic,
it's around $9,000, $10,000 for portable ones. I do like the wired ones because the battery, the connectivity, and VOs, when you use color, it uses battery, it overheats, and you have to recharge in the middle of a patient's VO. It's embarrassing. So that's why a wired one, plug and play, it's not going to switch off on you. It'll just work.
Yeah. Yeah,
That's my
push
opinion.
back on the price, but I've never seen it being that much of a problem. I mean, to potentially revolutionize your practice, to make you manage complications better, and also just differentiate yourself from other businesses, I think it's worthwhile investment. Trying, at least.
It's the same mindset as people that try and get away with using mobile phones and iPads for taking photos. And I was even talking to one of our medico-legal lawyers today that's coming on to have a chat with us in a few months, and people having the same mindset around having someone review their policies, procedures, their consent forms, their employment contracts, all that kind of stuff. So people don't budget for these types of things when they're sort of getting started in a clinic, or they don't appreciate the value of them. Everyone's willing to spend money on marketing and an expensive fit out, but they don't think about these other things. So I think it's just a mindset.
This might be controversial, but I'm going to ask Mobin to answer the question. Do you think that it's okay for people to settle for not being potentially the best injector by ignoring technology like this? Do you think it's okay for them to say, well, I've got an occlusion, I've tried my best, but I'm going to just send this to Mobin every time I have a problem?
I actually don't have a problem with that, because there are some incredible injectors, and I spoke to one, and I'm not going to say who the name is, but a KOL, fantastic injector, and she asked me the question, and I said, and she hasn't had a VO for God knows how long, I don't know. She denies even having a VO, which is hard to believe, because, I'm sure all of us, if you inject enough, it's not if, it's when. However, it's so infrequent that I said, well, if you're not having that many troubles, if it ain't broken, why try to fix it or introduce it, unless you really know you're going to apply this technology to your practice? But if you're learning and you're starting up, you may as well pick up the scanner and integrate it in the practice too. Even at the start, you're going to reduce and mitigate your risks potentially. Since I've introduced ultrasound, my issues and bounce backs have reduced astronomically in terms of placement rather than dissolving, of course. Dissolving I've been doing from the start almost. But in terms of placement, for example, I've got two areas. So when you augment a chin, midline, etc., I always scan that, because there's a little submental branch or a labiomental branch, a little blood vessel just hanging out there waiting to bite you on the bum, right? And I've seen it happen multiple times. Even I only just went a slight to the side, and then the whole chin area and under the chin's ischemic, right? So even a quick scan prior to injecting, I personally do the whole augmentation under ultrasound, particularly in males, or in females. Obviously, you stop at the alar. You don't want to masculinize them. But if I want to be more than 1 millimeter off the midline, and I'll do a pre-scan if it's just midline, but I still don't think you get as good a result if you're able to come off the midline to augment that mentum nicely with a bit of lateral augmentation as well, and safely, rather than just putting a blob in the middle and squishing it down.
So going back to my question, you're saying that it's probably harder for, someone super experienced to then suddenly learn a completely new skill, which I probably agree with.
I don't know whether it's harder, but it may not be necessary. Because they're already successful and they've been safe for a very long time, and they've got to have their own surgical audits.
Yeah, but as experienced injectors, they may well get approached by less experienced injectors around them saying, hey, I've got a problem. I've got this persistent swelling. I've got blah, 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 all the stuff that you and I get sent. And they will be doing it blind, effectively, unless they have,
Well, they probably won't get the referrals, will they? Which is kind of easier for them, isn't it?
Yeah, it's tricky. And I mean, I don't know if you want to talk about this. We can cut this out if you don't want to, but you said to me the other day, I think I'm going to rethink this dissolving clinic thing.
Yeah.
Getting stressful.
I had a moment I put things in place, because the expectation, even managing people's expectations, sometimes doesn't even work. And so I've actually created, and people can put this in their practice, but it's different, I guess, because it's a specialist referral. I now require do an MR first, because I'm in an area where people don't know what's going on. I believe MR is the gold standard. You cannot miss filler. It is, if it's there, it's there. Ultrasound, once it's integrated, it can be hard to see. And the way we inject has changed. We're not doing boluses anymore, right? Micro boluses, fanning, cross-hatching, it all ends up, think about some ink in a sponge, but you've got no color code. You're not going to see it on ultrasound very easily. Blobs, fine, easy. Fresh filler, fine. But after a period of time, and this is anecdotal, so don't quote me on it, I personally find it difficult to see. So I get an MR first, and then now I request a referral that this particular patient is managed, their skin is managed. So if you referred me someone, Jake, I'd say, this patient's still yours. I've got one job. And then they go back to you to either refill, which I will touch on that, don't like that, or go to surgery and get a referral to surgery, or something that may need rectification, which is in probably the majority. The minority get a resolution. And we can talk about who they are.
So let's take a step back. What kind of stuff are you referred? Like what problems have you seen in your time?
Okay, so the most common is, guess.
Well, it's going to be persistent swelling, eye bags, potentially nodules or things that don't quite look right and they're resistant to dissolving in the traditional way. Is that the kind of stuff you're seeing?
Pretty much. So under eye is the most common issue. And I get referred these patients who are pre-blepharoplasty. They go well because you plan everything out. You get an MR. I target where I'm going to go under ultrasound. If I can't see, it doesn't matter because I use the MR as a roadmap because I know it's in medial SUF. I know it's in the superficial plane, or I know it's in lateral SUF. And I target those areas 6 weeks before the operation, 4 to 6 weeks. And then I tell them, you're going to look bad. You're going to have wrinkles. You're going to look like you're deflated. All that stuff has to be said very, very clearly and signed off on a consent form. And I said, it will be a shock to your system. You will not like it. Like, these are the words that I have to use because, and sometimes they might be lucky, but generally speaking, no. But they have a resolution to the issue. You have to have a game plan after you do a dissolve. Or pre-bleph, I get referrals for malar edema, and it's 2 types of things that can occur from malar edema, right? It can be from the filler it's actually sometimes the malar edema is because of the filler, and it's sort of under the eye bags itself. There's also edema too. It's actually filler. So you just dissolve that, right? Superficially, you might be lucky and get away with it. But the other cohort, which I have found more and more, which is more common, they tend to resolve is inacanthus filler blocking the lymphatics. Right. So when you're in with a cannula and you're sticking it right up where a lot of the KOLs have been training and all these conferences, right up here to get that maximal pump of that tear trough, you're right up against tear trough ligament here next to the angular artery, which they don't prang. With a cannula, you're in a tiny space. And as we know from Mendelssohn and his cadaver studies, that your lymphatics either run from here and across and down, or from here up and across, or down across from the inacanthus in the nasolabial fat. But the vast majority of the drainage does have some inacanthus involved. So a tiny squirt in that area, using the artery as a landmark, often resolves these people within about 2 to 3 weeks, sometimes a few days, which is fascinating. I've had a lot of, they're the success stories, those particular ones. I try that first. That's the other most common for me, because I get referred. Delayed onset nodules, it can happen anytime, as we know.
What do you think's causing all these problems? Like, why are they happening? Is it bad injecting? Is it filler, rheology that we don't understand? Are people accidentally in the wrong plane, even though they think they are deep? Or, what's your interpretation of why this is happening?
I think a lot of it is placement. There's a lot of information about migration. However, when I MR'd my face and published the study, it might have moved and flattened by about 5-6 millimeters, but it doesn't jump to other compartments. It did not change compartments. We can clearly say that. Only one case, it's a pretty rubbish study, but there was nothing else. So at least we've got something, and we've got an MR to prove that it didn't move from compartment to compartment. So I feel that the first cohort, not the lymphatic one, where the placement is either just you're in the superficial plane. And I don't know whether, do you ever, is there any training to intend to be in the superficial plane in the orbit, or that's not a good idea?
I don't teach it.
Some people might intentionally do it.
Yeah.
The problem is the rheology is such that as it breaks down, the molecular structure starts breaking apart and it's potentially becoming more hydrophilic, attracts more water, and then it manifests itself. It was always there. It's just showing up down the track. So that is relatively common in that they come in a year or 2 years later. The other one is also misplacement and they didn't like it from the start. So that's a problem child too, because they still get a shock because they might like the puffy look more. So you got to choose, what do you want? You want the empty, saggy, or do you want the puffy? And often people will prefer the puffy. And I'll say, go home, sleep on it, think about it. It's going to look wrinkly. Or can you tolerate that little bit of puffiness? Because if you're trying to tweak, I'm not going to even entertain tweaking you with Hyalase, which is unpredictable. Hyalase is unpredictable sometimes.
What do you think would happen if we Hyalase David's face? How many years of filler have you had?
I don't know. I've had it done for many years, but not much.
Yeah, like little bits.
Yeah, little bits here and there.
But it's cumulative, as we know.
Yeah, I mean, I had my tear troughs done once back when I was at Cosmos in about 2006, and that's the only time I've ever had them done. So I don't know. Gosh.
Why don't you refer him to you know his history, don't you, Jake? Why don't you just MR him? Send him to Mater Hospital. It doesn't cost much.
He's seen every injector under the sun. But yeah, I mean, he's obviously had regular treatments. But yeah, it would be a cool study. Just get an MR of your face and see what it looks like.
Yeah, have a look at it and I can go through it with you.
Oh, it's a good point. So when that MRI came out of Alice Hart-Davis, Alice has been on our podcast several years ago. She's a journalist in the UK for people who don't know. And this story did the rounds in the Daily Mail of the UK because she'd had an MRI and lo and behold, there's filler in her face. And she didn't care. She looks great. And she celebrated treatments, and that was the end of her story. But the way that story was spun has continued to this day where people go, oh my God, filler lasts longer than, 6 months, 2 years. That's terrible. And suddenly it's got this negative spin to it. So what's your take on, you've done MRIs, you've done studies. Is there an issue?
To have the attitude that this is going to last a long time, so charge more and spend more time on it. Don't just wham bam, it's a bit stuffed up, it'll go away, because it ain't going away in a hurry.
Yeah.
If you've misplaced it, it's not forgiving anymore because we have the data now. Before it was forgiving because it's going to go away in a way, like toxin. You can get away with it. I mean, someone's got a crooked mouth. It's like, thank goodness it goes away, right? But in this situation, the other issue you have is because of longevity is that in older patients, particularly over 40 to 50, and if you don't have much coverage and you've done tear troughs and you block the lymphatics, often it can be relieved. It usually does, but occasionally the lymphatics are aging and they've been blocked for so long and damaged that it needs to go to surgery. So we've got to think about what we're doing before we inject it.
Well, we've got thousands of clinics. I don't know if thousands in Australia, but several hundred.
Yeah, there's probably thousands. I agree with you.
And, sometimes not that experienced injectors pumping lips and cheeks. That's what they learn at the start. And so that potential issue where eventually they get puffy, overdone or over-augmented or Tyndall, whatever, going to continue until we change how we teach people, right?
It has to be judicious. It has to be careful. You got to get the right plane, and you can get an ultrasound and it's pretty straightforward. Is just check where the blobs are, because it's immediately once you've injected it, it is visible.
But if you were in charge of training injectors across Australia, what would you do to change how injectors understand fillers? And also, what would you say to patients when they're having a filler for the first time? What do we need to change in the language?
So clinical, as we've talked about and we've touched on, clinical photography is absolutely essential. Similar lighting, similar circumstances or, conditions, so that you can show their face before, after, and if they dissolve down the track, has it gone back to their face with plus 2 years or plus 3 years? And often it's very hard to prove to someone that, hey, You had filler in there hiding your real face. Now you're 2 years older. It's not the Hyalase. It's what you would have looked like. And a lot of things can happen in 2 years. You've been in sun. You've got sun damage. You've lost weight. All these different factors. Your diet.
Yeah. It's a real valid new issue, being an Ozempic or GLP-1.
You've got stress. You know, all these things, a lot can happen in that time. And then when you dissolve it, I don't look like what I looked like back then. And as you know, with the vaccine history, everyone blamed everything on the vaccine. If you had diarrhea or you decided to vomit or, you know, you had a car crash, they blamed the vaccine. It's because you've had this injection and it's easy to just target that Hyalase injection. So I think I would say that judiciously inject. Congenital tear troughs is my mantra. If they are quite deep and they congenitally got a deep trough and they've got good, excellent skin coverage, then you get away with half a mil, maybe 1 mil maximum over a period of time. Then take photos and learn to say no because, hey, do I need more? But because of the monetization and the financial components, you need more here, yeah, a bit more here, and here. I call them und hier doctors. Und here, inject und here, und here.
How do you combat that for people running a clinic and, you know, someone comes in, an eager patient wanting more and more? How are you teaching your mentees to be ethical but also run a business?
It's a difficult one because money and medicine don't work together, but they kind of have to, because without money, there's no innovation. No one's paying for these studies. No one's paying for new product development. So it's difficult. I think that a lot of people start businesses and have pressure put on themselves by the expectation of growing faster than what's actually possible. And then if you're financially being pressured to try and make more money through your business, then is your decision-making process potentially compromised? And I think that's a real thing. So I think people planning for things to take longer, having other sources of income while they're building up their practice, and just thinking about long-term. If I take care of my patients and forget about the money is a second-order issue. It should always be about what's the best for my patient and growing their business slowly and not putting financial pressure on themselves, because a lot of these decisions aren't even conscious. They might just be subconscious thoughts, like your mind gets to a point and it takes, you know, this track instead of that track. And before you know it, you've overfilled someone, not because you're trying to scalp them for money, but it's just the way your brain's thinking because of the financial pressure. It's difficult. It really is.
Yeah, 100%. Mobin, your first paper was entitled Hyaluronic Acid Filler Longevity and Localization, MRI Evidence 2021. I think it was 2021. Is that right? Mm-hmm. So basically, what summarize that paper? What did it actually show? We've sort of touched on it, but what's the evidence? How long does filler last? And more to the point, why does it last that long?
Well, that first paper was kind of the pilot that required, it was the platform on which I did the larger study, but this was the first study where I just gathered the patients that had longevity and also just showed MRI as a useful tool, as road mapping to find where the filler is with nice static images. Mm-hmm. And you can unequivocally and categorically find the anatomical planes in which the filler is and how much there is. And the idea was this concept of MRI roadmap to an ultrasound dissolve, which is exactly what I specialize or have created. This is a sort of a pioneer technique, which is we use it all the time. I use it in, ultrasound in the hospital for various other organs, etc. You're using the roadmap of the technology of one technology, and then you use the ultrasound to localize your needle to make sure you're in the right spot, or find and go, oh, there it is. So that was the main purpose of that one. I think there was about 6 or 8 denied filler for 2 years, and there was clear evidence of filler. Mm-hmm. And then the later study that took me over 2.5 years to write and about 15 revisions before PRS accepted it was 33 patients, and that vast majority were recruited new patients who denied filler for 2 years. A lot of them didn't know what the product was, which was a big problem.
Right.
Some of them didn't know the volume. And one of them had just residual bits of filler, but hadn't had anything for 15 years. But I think she had 6 mil which is a fair bit. But even after that much time, the residue was still there, which we thought it was just like, it disappears. So that was the crux of both of those papers, to just say that it can last longer. However, the big study that we can sort of emphasize was only in the mid-face.
Yeah.
The lower face, we need more info. And anecdotally, I've seen, a certain product in the lips just disappear after 6 months, completely in the lips and the chin.
Yeah, interesting. And did you anecdotally notice that all of the brands have a similar longevity?
Yeah, there was a bit of a skew for some of the brands, but they've been in the market for longer. And then the ones that have been in the market as long weren't as represented, which is just pretty obvious math.
Yeah. I mean,
there was no standout.
Yeah, it sort of makes sense, right? I mean, yes, we were teaching injectors and also telling our patients you'll get a result between 6 months and 2 years, depending on the product that we put in. But I don't really think we ever meant that the filler is going to magically disappear from the tissue completely. We just meant the clinical result won't be as good in 2 years.
That's true.
I don't think we ever didn't tell people that, but the interpretation was it would just
it's gone,
disappear overnight.
I don't know. I that was the way that I always understood it, was that it would just get dissolved, the body would break it down, and it would just be peed out. That's basically the way that it was presented to me.
Peed out.
Yeah. Well, your body would just deal with it and remove it. So it was never nuanced to the point where people would say, "Oh, the clinical result won't be as good, but it's still there. We thought it's gone."
I mean, it's a bit of a paradox, right? Because if you're saying, Mobin, you're scanning faces and there's 6 mils of filler 15 years later with no new filler, why doesn't it have?
There wasn't a lot left. No. It was only residue, little bits and pieces.
Oh, okay, fair enough. But I mean,
there wasn't a huge volume left at all. But the point was that there is still something. The body hasn't broken it down completely.
Okay, fair. So are you able to speculate or comment? You did 33 MRIs of mid-face. How quickly does it take for the clinical result to actually go away? Because, when I do under eye work, I do quite a lot of it. I can see people 3-4 years later, 5 years later, and they still look great.
That's fantastic.
I'm like,
that's what you want.
Don't need any more. Like, I'm not doing more. Sometimes they come because it's been 2 years and they're like,
exactly. And if you do more, you're going to regret it.
Yeah.
Because it's like a bowl with a fixed space. As soon as you tip over the edge, all hell breaks loose.
Yeah, no,
I don't want to tip it over that edge.
But it's actually a wonderful issue. It's lasting a long time. You don't need to do it every, 1 or 2 years. It's the best investment, assuming your result is good. You don't need to keep on doing it. So it's more cost effective than toxin or laser or anything else, because it's there, maybe not indefinitely, but for many years.
You do have a problem in the Gold Coast, though.
Well, what's the problem?
Exclusively bigger problem than anywhere, I think, in Australia.
Tell us more.
The population, fixed population, 690,000 or something? Not many people, right? Every street corner has an injector, has a clinic, every single place. And the prices are so low, in order to make bank, they have to use more product. And that's why we've got an overfilling issue up here. The per unit of neuromodulator is 40% less than Sydney, or 40% less than Melbourne, probably 50% less than Sydney.
Wow.
It's not worth me. I don't bother. I just do the dissolving up here. I don't do not much of that work. There's no point. There's too much competition, and it's too cheap. And if it's cheap, it means you can have more product, right, for the same price. Yeah.
I mean, we've sort of observed over time that maybe the aesthetic changes depending where you are in Australia, and there's a bolder look in the Gold Coast. So is it a problem? Is it? I mean, it's just a taste issue, or are you actually seeing more competition in the average town and city?
Well, I think they like it, but my concern is that there is going to be problems down the track, especially for these young patients, when they're overfilled and then they want to try to get rid of it, and their skin is all stretched out, and then they're going to have a shock of their life. Their lymphatics might be blocked, or their lips. I don't see it on MR or imaging, but I believe that there is a level of well, I know from the studies that there is a level of inflammation and an autoimmune response to all the BDDE, the cross-linking and the actual filler itself. So that immune response and the long-term inflammation may cause a low-grade fibrosis. And when you have that, if you ever want to dissolve, it can be difficult. I've had lips that I cannot for the life of me get down to normal. So, especially above the vermilion border.
And as you're saying, with all fillers, obviously the more cross-linked they are, potentially that's more of an issue. But
potentially, yeah. In terms of getting rid of it certainly some products can be harder to get rid of than others, and you have to bombard it more.
But are you still saying it's quite rare in the grand scheme of things? Like, can you give a number and a percentage of how common that is?
It's relatively, in terms of, I found lips difficult when patients have problems with lips and they can't get rid of it. I need multiple sessions to try to get things down. And I don't know what's happening, but the vermilion border is pumped up and it never comes down.
Yeah, I've often wondered whether that's just because they've had potentially 10 plus lip treatments, multiple needle passes that creates fibrosis.
Fibrosis, yeah.
You use the word filler migration. I wondered if you want to sort of clarify what you mean by that. But many patients come in talking.
I think there's more diffusion. The most important thing is placement. I think the vast majority of the issues is incorrect. If it is filler on MR, it's incorrect placement. But migration in my face, as I said on the MR, there's just a little bit of diffusion and spread, I call it.
Yeah.
Kind of diffuses and flattens a bit, a few millimeters.
Yeah.
But when people are talking about, I had filler, in under my brow and now it's under my eye in a different compartment.
Not possible.
It's not going to happen.
Yeah. That's my stance on it. But what's happening around the mouth then? Why do people turn into Marge Simpson with this beak of filler above their top lip when the injector is adamant?
I reckon you're right. It's fibrosis, because when you just, I don't know whether you noticed it, it doesn't go away sometimes in people, and a lot of people that have that projection, that vermilion border.
I mean, it's certainly less common now. I mean, do you see people walking around Sydney with massive lips, duck lips? I feel like
is that a trick question?
No. I really feel like it's kind of done its course now.
You see less. I think you see less of it.
Yeah.
Depends though. It depends on what area of Sydney.
Yeah, I mean, it's the language like migration and ultrasound. These things are now known quite well by patients, and they come in fairly clear on what they think the phenomenon is and why ultrasound should be used, and almost telling you what to do. Is that your experience, Mobin, when you meet patients, or not really in the Gold Coast?
So now that I've changed the protocol, it's referral base only.
Right.
When it comes to a dissolve, injectables, fine, no problem. Botulinum and skin treatments, etc., biomodulators, no problem. They can come off the street. But people that do their research or have gone multiple places who don't have a base injector, they've never been an issue and their expectations have been met. And then always when I have a dissolve patient, they've got a home to go to rectify it. Yeah. My job is now, when I get referred to dissolve, I got one job.
Dissolve.
And I go through the whole issues that may result, and the fact that more often than not, it may need rectification.
I just want to know how you manage these patients, because I still haven't quite cracked how best to do it. But you're saying
so
best with a referral.
I'll give you a copy of my consent form, more than welcome. It's about a 15-page document. No, it's not that bad, but it's about 3 pages long. And it includes, in the areas treated, skin laxity. There is this post-Hila syndrome where people think that their whole face and neck or face has become lax because of an injection in one spot, which makes no sense.
Yeah.
Mm-hmm. If you had an immune reaction against Hyalase, what would happen?
Your
hyaluronic acid would go crazy. Yeah. That'll be fantastic.
Yeah.
I'd bottle it up and rebrand it. So it's not an immune response, and a lot can happen over a period of time, and people blame a lot of things on Hyalase. I manage their expectations, so it's all dependent on case-by-case basis. And if you warn them of the worst, there's a lot of cases where I go through the MR, I talk about the risks and benefits, we have a long conversation, and they walk out of there with no treatment. Because I will say to them, and when you know, Jake, if someone has got, I look at their MR, if they've got a face mask of filler, my report should say all compartments full except 4. That's a lot quicker than mentioning every compartment and how much filler is in there. I might as well, everything's full except for the nasolabial fold.
But do you genuinely see those patients? Do you genuinely see
Yes, that? I've seen quite a lot of those. So those are the kind of clients, my under eye is bothering, blah, blah, blah. You touch that balloon, you will pop. And I say that in those words. You touch that, it's like a balloon. You've got a face mask. I'm pretty brutal. You've got a face mask full of filler. It's holding up your skin. If I touch that, you will pop. So are you willing to have that pop and then have to rectify it and spend even more money to maybe possibly get back to where you were? Because I think you're going to get back to where you were. Come back and see me. And this is the older patient. Come back and see me when you're ready. Tell me where your facelift is going to be. Get a referral from your plastic surgeon. If it's a deep, plain facelift, I will dissolve the areas after your MRI 6 weeks before, all the areas involved, and annihilate those areas and then go and get your facelift. But otherwise, those patients, it's do not touch.
Yeah, patient psychology in these kind of cases is super difficult. We did touch on it with Dr. Ezra, but I find these often the trickiest cases because they're never happy.
That's why I was shaking my head the other day, because they can actually drive you loony. But my new referral system, not just an MR, I am not your doctor. I'm a specialist, and you have your general skin doctor. So they go back for the rectification, or you go to your plastic surgeon for surgery. I'm orbital filler dissolving. I very rarely recommend refilling. And as I said, the rectification of lymphatic obstruction in acanthus is a great technique that I've been using, highly concentrated. And if you're really worried, you're not going to believe this, I do 5 units aside. And sometimes I get them to come back the next day. And I'll say, did anything happen? And sometimes they say, yeah, it's enough. 5 units, can you believe it?
So what's your normal, dose and dilution for a standard dissolve? There is no standard dissolve, but what's your typical approach to dissolve?
Well, if you really want to get nodules, I do 100 units per 0.1 of a mil.
Mm-hmm.
So 0.05 of a mil, whack-a-mole. Yeah. So nodules, DONs and stuff like that, you go into them. If it's just 1 or 2 isolated ones, and I barbotage, it's a radiological word for a bit barbaric. I go in and out of the wall so that the Hyalase penetrates. That's why you can't get it blindly. If you inject around a nodule, your biofilm's protecting it. You need to stab it and go in and out and make a few holes and get that Hyalase in there. However, if it's pre-facelift, Peter Callan and I did an MR and followed up this patient quite a number of times who had the biggest nodules I've seen in my life on MR. Balls. No antibiotics, no steroids, no nonsense, just Hyalase, 7 sessions. He got rid of the lot.
Yeah.
And I gave him a roadmap on the phone. I said, buccal fat pad next to the teeth, that's all that's left. Or in the cheeks, deep plane, superficial compartments. And he went in there. But with those cases where you want to annihilate pre-facelift or they just want to get rid of it, I put about 500 to 1,500 units in 20 mil. Hyper diluted and just smash it.
Okay. So
everywhere.
What would your advice be to people without ultrasound? Just, they think there's some filler causing puffiness, a problem. Should they still be flooding, or should they be referring to someone like you?
Well, it depends on what they want. Look, if you haven't got the experience with it, I would highly warn against it. It's not gratifying work. It's like being a director of training or a principal of a school. There's no gratitude. You just get complaints.
How do you even charge for something like this? How do you sort of organize your pricing?
Well, I think the pricing is difficult, but it depends on, I don't base it on product. I base it on areas. So if I'm with the ultrasound scanner and I'm doing just the cheeks, it's a baseline price. The consult is a reasonable price because I go through the MR. I've got to do homework. I've got to spend time looking at the MR, going through it all, looking at a potential game plan, looking at all the compartments and going through it with them and showing them where it is. And then I correlate the MR with their issue. So they draw on their face. I look at the MR and I go, that's filler, that's not filler, that's not filler. Or one patient came in and said, blah, 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 blah. And I go, no filler, no filler, no filler. That's you. Thank you very much. Merry Christmas. I'm not touching it. Because if you went ahead, poor blind injector goes and dissolves, nothing happened. I want my money back.
Yeah, it's a good point.
Sorry, I sound frustrated, but I am.
It's okay. We're like a therapy session here, Mobin.
Yeah.
Oh, mate. It can do your head in. So I was sometimes I'm very close to occasionally when these patients bounce back and you just can't get through. You sometimes think, is it worth it?
What does your insurer think about you taking on this work? Did you have to have a conversation?
It was very hard to get insurance, and I eventually did get insurance.
Because I don't think that many injectors think about that angle as well. If they're taking on elective dissolving of lips, which is probably the most common one, and patient goes, that's rubbish, I've got new lumps, I'm taking to court. I mean, probably a bit extreme, but could happen.
Look, I think I'm pretty well protected in that they've already been injected with something that caused the problem. I'm trying to fix it. Yeah, so the one that's trying to fix it.
New problem, you did it.
Hyalase is very safe. I think you'd have a pretty bored lawyer who'd want to take on the case, to be honest.
Yeah.
Well, they exist.
Yeah, they exist.
It's called Saul.
Yeah, better call Saul. Yeah, exactly.
Yeah, it's a really tricky one. I don't think this is the type of work that anyone should just sort of do blindly thinking, yeah, a bit more.
It's not the type of work that I probably should be doing.
No, I mean, the more I've done it, the more I have, a bit like you, Mobin, I probably haven't insisted on MRIs every time, but on my intake form, I insist on an intake form. I won't just let people book. They've got to explain the story. What happened? What have you tried? Have you had Hyalase? Who's your injector? I want to know the whole story.
Absolutely. And
there's something in there that says, I might ask for an MRI before I see you. So are you willing to do that? And everyone says yes. But then, if you actually get to the point of asking them to organize an MRI, it's not the most practically easy thing. They're
not cheap either, MRIs.
Well,
no, look, up here, the imaging place, Loomis, I can report any MR face from Australia because I've got a workstation at home at any Loomis around Australia, and they're everywhere. So I can personally report them. So I think you've got some in Sydney. If you just put to be reported by Dr. Master and put in brackets Queensland Loomis, then they'll earmark it to me and I'll personally report it for you. So you get a proper report. Well, I mean, the guy at the MARTA, he's fantastic too. I trained them, but I can now personally report any Loomis around Australia. In Victoria, it's Lake only because they really back me up on the research. I owe them everything for that. If it wasn't for Lake, I wouldn't be talking to you right now probably. So we do it at Lake in Melbourne. I think it's $390, and Loomis can range from $250 to $350. I mean, go to America and have an MR, it's $5,000.
Yeah. Well, I'll tell you what I found difficult is that, I send a referral, patient goes to the hospital and, hopefully they get a scan. But often there's a call from reception and who are you? Why are you doing this? And just takes ages to organize. And then when the scan is done, I can't ever get into the report. There's this special login and, I don't have one.
Yeah. What I'd suggest is do Loomis. Just get one login, save a login so you've got access to the images. And then I'll do your reports for you, and you can scroll through the images yourself and see if you can actually, it's just white bits, looking for white bits. You might be able to,
start listening, send them to Mobin.
You can just give me a call and I'll remember the case. But I think if you can stick to one radiology company and get a login and access, you can just save it to your passwords and log in and then just type in the first name, last name and date of birth and it comes up. And the report comes up as well.
So portals. It seems clear why you're ordering an MRI, but just, for people listening, what are you actually looking for? And then, of course, once they're in your room and you've got the report of an MRI, but you've got an ultrasound.
I don't have a report. I look at it myself. The report's useless.
Okay. So literally you've got
It's my report. It's technically my report. I actually usually report
the scanner on the cheek as you're looking in the MRI scan, slice by slice.
On the laptop. But what I also do is they mark their issues, and I look on the scanner and I can tell them without even picking up an ultrasound probe if it's related to filler or if it's not, or if it's related to lymphatic blockage because they've got some here. I can find anything that's misplaced because you can see everything. And then I use the ultrasound. Great. If I can see the nodule, fantastic. Sometimes you can't. I use the ultrasound to know the location of my needle exactly. So if I look at landmarks, so if I know this patient has got encasement of the infraorbital artery and nerve on MR, which you can find clearly, get the probe on, find the artery and the nerve, squirt some Hyalase, go for a walk, come back, have a coffee, let me know if the pain's gone away. Did that successfully with the temple as well. The superficial temporal nerve was compressed, nerves run with arteries. She had this burning sensation since she had temples done in the superficial plane for 6 months. Came and saw me under ultrasound, 30 units. MR, I could see it in the temples, and it was near the artery, just under ultrasound. Couldn't really see it because I think it might have been almost a year old. Couldn't really see it. I went superficial along the frontal branch of the superficial temporal artery, did a linear retrograde thread of 30 units in about less than half a mil. Got her to go and get a coffee. She goes, I think it's gone, but I think it's the anesthetic in the product. I said, well, go away, come back in an hour. Came back in an hour, she goes, the pain's gone.
Yeah.
So that's where it helps in precision, particularly when you've got symptoms like pain or burning, or you have persistent swelling. You've got precision in terms of this correlates with what you're pointing to, or no, this is your face, or this is lymphatic blockage, because you've got malar edema, but there's no filler there, but there's filler here. So I'm going to just put a tiny test dose here and here, come back tomorrow, or come back in 2 days.
I was going to say, how do you know that they have lymphatic blockage, or is it just a test? You put the Hyalase in and see?
I put it in there because on MR I've seen it. I've seen inacanthus filler.
Right.
Which seems to be, anecdotally so far, a successful place to relieve lymphatic drainage.
Okay.
And the malar edema goes away. It's like a miracle. They're the happy cases. I mean, there's a few of those.
Leonie and those guys in Holland, when they're sort of doing their research on VOs, where are we at with what is a VO? Do we still think it's filler sat in a vessel, or do we think it's irritation and spasm of an arterial bed? Like, what's your take on what you actually see and what your ultrasound shows?
I've been doing some reading and research on a lot of papers on filler blindness, embolization, thromboembolism, and what the causes could be, which is relevant to occlusion of these vessels. And I believe it's a combination of both filler embolism and potential proximal vasospasm of the vessel, right? So if it is to be thrombus, you would have a delay, whereas we know that vascular occlusions happen at the time. But this is a deduction, so you can't quote me, and we don't know. We still don't know yet. This is the problem. But with logic, and I spoke to interventional radiologists, and I'm an interventional, but the vascular radiologist, the neuroradiologist, and they said, well, if it's immediate, for example, there's cases of stroke with filler, showered the whole brain. If it's immediate and the symptoms are immediate, then it's filler embolism. And when I saw that showering the brain, it explained some vascular occlusions whereby a whole territory, the submental artery territory, was knocked off, but I had to chase multiple distal areas to relieve the occlusion. And the proximal vessel just relieved itself. I'd still injected around there, but I don't think that was the problem. It was in spasm because the patient had the artery cannulated and it just showers all the end vessels.
Yeah.
And remember that the cases that you see, correct me if I'm wrong, Jake, you've probably seen a lot of vascular occlusions now. You do have a bit of forgiveness in terms of time if you are Hylasing. Your Hyalase also releases nitrous oxide, so it vasodilates, and you get this paradoxical improvement when you're watching, oh, I got it. and then half an hour later it comes back.
Yeah.
But that process also does reduce the risk of necrosis. So I think a lot of these cases they're vascular occlusions, but they're more so ischemia at threat skin, because you've got so much collateralization. I think there's a lot of forgiveness in the face because other vessels are sort of supplying it. And then after time, you get some collateral circulation that creates some forgiveness as well. So that's why some of these VOs, and I've seen a few cases under ultrasound, they drag on for 4 to 5 days. They give me chest pain, but I eventually get them.
Now, I'll tell you what I asked. We had Jason McKayser on from ARPRA, and I didn't really appreciate this till he, I guess, verbalized it, because we asked him, what's the issue with regulation? Why are you guys so worried? What's the issue with patient safety? And he kind of quite rightly said the problem that we notice is that patients who get into problems like VOs or lumps, bumps, they're often kind of not turned away by their treating clinic, but the injector sort of throws their hands up and goes, I don't know what to do now. And so these patients are sort of lost, and they're floating around and they're Googling, and they probably come across people like you. And so it's actually a major issue that, we've got clinics and sort of volumes of injectors.
They get to their limit, right?
There are many clinics.
Yeah.
There's hundreds of them. And so what do we do with these people when they desperately need help? Because
they're at the limit of their knowledge.
Right. But they're still happy to inject.
Well, that's the thing. Because in my game at the hospital, if you are going to do a lung biopsy, then you should be willing to put a drain in and an underwater seal drain at the time, which I do all the time, because there's a 30% risk of a pneumothorax. So if you're willing to inject it, you should know how to reverse it. If there is a long-term issue, you should know how to reverse it and manage it. But it seems that only the training is focused on the injection component, as you're pointing out.
Yeah. So what do we do about that?
Well, I think there should be training on it.
Yeah. I mean, I don't know how do you train someone to dissolve something? How do you create a situation that you're then going to dissolve? Because otherwise it's just theoretical, isn't it?
Well,
it's theory. It's theory.
I held a basic ultrasound course 2 or 3 years ago with the guys from Holland, and we got a chicken leg and we shoved some filler in and we did it on ultrasound, and we learned how to do it. Everyone could practically have a go on day one of an ultrasound course.
True.
So that could or should be something to think about when training new injectors.
I do offer shadowing, by the way. That's the only training I do offer. So I do some shadowing. If there's a big list of dissolves,
I'm not
any injector can shadow me for a day or half a day, etc.
Yeah, I'm not knocking anyone in particular. I just sort of feel like we need to think about what we're doing here.
Well, I don't think anything's going to happen until it's forced, to be honest with you.
Yeah. I mean, it's a little bit, it's a bit of a stretch of the analogy, but it's a bit like saying, I'm going to train to be a nurse or a doctor, but I'm going to skip the basic life support. It's a bit boring. It's not really my thing. I'm just going to do the cool stuff, but I'm not going to do the emergency stuff because it's kind of rare and I'll just give it to someone else.
It's like learning to fly a plane, but you don't know how to land it.
Yeah. I mean, hopefully that's
right.
Much of a stretch, but I think that, you go to every conference, there's a big section on complications, and, we all kind of know what we could or should be doing, but I just don't know how many people are willing to actually upskill themselves.
I think
one of the most popular sessions, though.
Yeah.
Yeah, because it scares people. But it's all theoretical. Until you have to manage it yourself, you think, shit, I hope it doesn't happen to me, and I'll just sort of give it to Mobin.
Wing it.
Yeah, exactly. Or wing it. I don't know. I don't want to be harsh on injectors. I just sort of feel like, how do we up our game?
I think the industry will sort itself out over the next few years. I think we've already, Mobin's already talking about the oversupply issue in the Gold Coast, and that's bringing the price down. And then with that is reduction in quality, patients getting more and more filler put in their face. But as I said, we've spoken about, and as we've spoken about many times before, every market reaches a point of consolidation or it matures. This industry is still relatively immature. And so as we learn more, as it becomes more common knowledge that these complications can occur, the reality of how long filler lasts, and so on, I think that the regulation will eventually catch up. I don't like unnecessary regulation. I think it needs to be sensible. It needs to be fair. You need to give people time to adjust and get their practices in line, get their training up to speed. But I think this will probably sort itself out as the knowledge grows and the industry standard improves, patients become more discerning. I think you'll see people either upskilling, leaving the industry either by choice or just being forced to, patients demanding certain qualifications, levels of experience. I think it's just we're in a adolescent phase of our industry. And I think it's just the nature of how every industry goes. We will get there, but it's just we're going through a rough period at the moment. What do you guys think?
Well, I think that's a reasonable statement. But in the interim, I think Jake in the back of his mind is thinking, well, what do we do right now? That's your point, right? Like right now, this is what's happening. So like delayed onset nodules, I don't think it's an injector's fault. And I get referrals where the actual injector wants to foot the bill and I feel bad and I give these discounts, but I'm lumbered with this work and a difficult case. And they do go back to their injector, but this is sometimes how it works. Or do we have a few specialists in this area in each major hub?
Yeah.
And if you've caused the issue, whoever the injector may be, would they be willing to pay some serious fees?
Or you just pay membership.
They don't know how to manage it, which they probably should if they're not going to manage it.
Could be like a membership where people just pay a monthly membership to be.
Well, that's what AMET does at the moment.
Yeah, but I don't know. Do they have people practically? I know they've got different providers around the country, but I don't know how that practically works.
I get some patients through AMET as well, but that's more focused on emergencies.
Yeah,
that's the problem. They don't really, long-term swelling. They don't really hit them up for that. More emergencies.
Yeah, I'm also curious to know just how common this complication problem is. I don't mean VO, but just patients walking around with not good aesthetic results.
Especially under eye, it's very common. I see them out there. I was talking to who works at an injecting clinic and she's the owner. And then she goes, oh, by the way, yeah, I'm a bit and you can just see the superficial filler and the tyndall around her eye. And I said, you're at an age where you probably need a blef if I dissolve that. And she goes, no, just leave it. So you're dodging bullets constantly with these kind of cases. But yeah, they're walking around everywhere. It's
hard to quantify the scale of the problem when patients essentially tolerate that versus dissolving or actually getting fixed or whatever. So when we start talking about statistics of how common a nodule is or tyndall or whatever, I don't think we really know. I think we're just sort of...
No, but the issue is that it's not great work. And there's a lot of it floating around. We don't quantify it. It's hard for me to quantify because I get the majority of them.
Yeah, you're at the pointy end. You kind of see it every day. Well, you probably think it's super common, but maybe it's not.
I feel like it's common because I see. Well, the other thing I wanted to touch on as well, the puffiness and the DONs, what I've noticed more frequently is the classic history, and we learnt this during COVID, is post-viral or post-bacterial infection or a high immune response, and then the filler puffs up, auto or immune response against the filler, and it just won't go away. And they have to take steroids and no one knows what to do, and they end up having to flush their entire face to get rid of everything. And then you got to go whack-a-mole and chase all these nodules and break them all up to get rid of them over another 2 sessions.
So your stance on nodules is essentially filler. That's one risk factor, because without it, you won't get a nodule. 2, implantation of bacteria or makeup or whatever at the time of the fillers put in. And then 3, there's a trigger often, dental problems, chest infection, UTI, whatever. Is that your understanding of how nodules come about?
Yeah, 100% agree with you. And the trigger is the most important thing. If you don't have that trigger, nothing may happen. I mean, why did they not have a response to their breast implants? The breast implants were perfectly fine, but they had a reaction just to the filler.
Well, it's interesting. David just randomly mentioned this many podcasts ago. He's got tattoos, and he said when he's not feeling great or maybe it's sort of pre-flu, his tattoo sort of gets bubbly. A bit more lumpy and bubbly.
Yeah, in certain parts, yeah.
So and with anything foreign in the tissues, the immune system goes, what the fuck's that? And and create some swelling.
You're getting foreign body reaction and a hyperimmune response that will attack foreign objects or foreign material.
Seeing as you're dissolving filler every day, can you confirm or deny that certain fillers are more likely to cause nodules, or do you see it with all brands?
Same with everything.
That's what I thought.
The only thing I will say is some of the stuff is harder and you just got to use heavier doses. But there is no one brand that stands out that causes these nodules. All of them, any of them.
Yeah, I mean, what you see peddled online is it's only X brand.
No,
anyone who manages complications regularly sees it with all brands. And
absolutely.
It's just a phenomenon. You've got filler that's cross-linked in your face. It can react.
I don't even know how. I mean, Mobin might say that he may see more of a certain product, but if that product's been around for longer and been used more, then that you're going to have a disproportionate number.
That was in the study. That's right. It's been in the market for longer, and then the ones that were poorly represented have only been.
I'm talking about Juvederm, right? That's the one that normally gets the bad rap as the one that causes all the issues. But that was the only show in town for like 10 years in Australia.
Yeah,
at least. So I mean,
it's poor understanding.
Oh no, it wasn't. Sorry, it came around. Sorry, I stand corrected. QMed. Restylane was there first, but I mean, really, out of those two products,
I've seen problems with all of them.
Yeah.
All right.
And Restylane and Juvederm were highly represented because they were the first in the market.
Yeah, exactly right. So
you've got to use common sense and understand these studies and read them carefully without just jumping to conclusions. And I would like to touch on, if you don't mind,
sure.
What are your thoughts on the Hyalase phenomenon, the post-Hyalase syndrome? Because I've used it and I use it judiciously. People have had it before, and then there's these claims that it destroys the entire face and it's done this and it's done. I've used it for 8 years very safely. The only problem I had is I told you about maybe previous podcast. No, in the interim, face mask full. And I was used to doing 100 units all the time. And I learned from this. Pop. 48 hours, it just kept going and going. So you get an initial response, and then I think over the first 6 to 8 hours, you really get this uptick of dissolving, and then the swelling starts coming down, and then you actually see the result. You know what I mean? It crosses over. So once the swelling comes down, you can actually see how much of a trough has been created. Massive trough, just complete collapse, disaster. Just to get rid of a lump around the eye, because there was filler everywhere, every plane, everywhere you can think of, right? This did not destroy her face. It just got rid of the filler that was puffing out the eye and puffing out the skin.
Yeah.
I mean, I didn't have a jawline. I've had 6 mil in the jawline. Doesn't look quite as amazing as Jake's right here, but that shadow wasn't there. If I take that away, you'll see no jawline and a turkey neck. Oh my God, the Hyalase destroyed my face.
Yeah.
No, it didn't. It took away the filler. So I think it's I think it's safer than filler, to be honest, Hyalase. People are petrified of Hyalase, and I say to them that the filler is worse, much worse, because Hyalase, you've got your own Hyalase, and it's closer to your natural Hyalase than hyaluronic acid fillers are to your natural hyaluronic acid. It's also turns over in your body, and it's gone within 48 hours.
Yeah. So you're saying, because we're often told the half-life of Hyalase is about 3 minutes or something silly, but you're saying you effectively notice
the effect take a bit of time to assess. So
because you're pumping in liquid as well, right?
But yeah, well, because I've got limited time, if I'm really petrified of the result or the patient's petrified, I do a test dose, as I said, below 10 units. I had a successful case where the MR showed it was in her eyelids. The reason why it was in her eyelids is because someone had done tear trough but didn't feel for the low-lying orbit. So the orbit was way below her tear trough. So you've just gone in skin and you're not on bone, and it was in the eyelids and in acanthus as well, and particularly the inacanthus for the lymphatic drainage. So this was twofold. I injected 10 units in the lid, 10 units here, and a little bit in the inacanthus under ultrasound. Very carefully made sure I was right in the superficial plane. I made her sit in the waiting room for about 10 or 15 minutes. She came back and there was no effect. And I'm like, oh, I don't really like this much. And I learned from this case. I gave her another 10 aside and I said, go home. And then that night, she goes, yeah, I can't tell yet. And she had malar edema. That night, she was walking her dog. I was in St Kilda getting a pizza at 10 o'clock at night, watching my brother do a gig. He's a guitarist. And I saw this woman go, look at me, look at me. Literally a normal eye bag and the malar edema. She looked like she'd been punched. That swelling and that edema, completely gone with 20 units aside.
Yeah, interesting. I don't believe in post-Hila syndrome at all. I think it's garbage.
There's no papers.
Yeah, I think, like I said, it's just tons of filler, perception drift. People forget what they used to look like, plus, several years of aging, and you remove it all and their face collapses. Obviously, it's just sort of expected. But if you don't...
And some people think there's a delayed onset over a few months, and you're like, well, what did you do in those few months? As we talked about before, did you lose weight? Did you go in the sun? Did you, not get any skin treatments? Didn't use your face creams? Are you under stress? All these things.
Have you encountered anaphylaxis with Hyalase? You're using a lot of it.
Angioedema, yeah.
So what does that look
like? I did her lips. And she said, oh, last time they swelled a lot. I said, oh, let's do it. Let's see how we go. Instantly regret it. They just blew up like a balloon. I didn't have IV, which I recommend everyone has IV hydrocortisone in the clinic. You put in IV gel coat and you just pump 100 milligrams of IV hydrocortisone. I gave her 50 milligrams of prednisolone stat, plus an antihistamine, and I kept her in the clinic and watched her until she settled, and within 2 hours she was fine. No itchy neck, thank goodness. We've got adrenaline, though, if we need it. And my colleagues were like, adrenaline. I said, do you know how rubbish you feel with adrenaline? Do you know how sick and disgusting you feel? I couldn't even bring myself to give that unless it is life-threatening. I will not give adrenaline.
Yeah.
But I work in a hospital. So, you say I Hyalase every week, but I'm at the hospital at other times in a hospital settings doing injections. And, for example, tomorrow I'm at a radiology clinic, and in 8 hours, I'm going to do 50 ultrasound and CT-guided injections, one every 4 minutes.
That's mad.
It's mental.
I'm looking forward to that. Good luck.
My colleague said, I go, do they bring you lunch? And then he said, don't worry about lunch. You won't be having lunch.
Catheterize myself and crack on. Yeah.
That's right.
What do you think about the whole bee and wasp allergy, and can you or can't you have fillers because of the risk of needing Hyalase?
I don't know. I really don't know. If someone has a severe allergy and anaphylaxis, not particularly to bees, but to certain things, or has a big list of allergy or autoimmune disorder, I don't touch them. No filler. Not worth it.
Not worth it.
No. When you have a big list of allergies, there's an increased chance of you having an allergy. If most of the patients have already had a filler, I won't touch them. But if they've already been touched, and then should I see an immunologist? There's all this complicated stuff. I said, no, you can come and see me. Insulin needle, tiny little squirt of Hyalase in the forearm, draw a circle, and then come back and see what happens. And 99, well, I haven't had any yet. The test, I had one that ended up with a rash that got a bit bigger, maybe 1 to 2 centimeters, rash in the forearm. So what I did is just pre-medicate her, as we do with IV contrast when you have a CT scan, pre-medicate her with 50 milligrams of prednisolone, 50 milligrams on the day of the procedure, and 50 milligrams after the procedure. No swelling, no anaphylaxis. She just happened to have a big rash there. So you can pre-medicate people prior to Hyalase if necessary.
Yeah, we've had Gillian Murray on the podcast. She's sort of doing a PhD in Hyalase, and she fairly strongly feels that these patch tests or intradermal tests with Hyalase, she think it's you can't really interpret it that way. But I don't know if you've got any other thoughts, but I mean...
Well, I would believe her because does she know her stuff, especially about Hyalase? I need to have another conversation and pick her brains. I love getting knowledge for free.
Gillian's great. But I guess my point was, don't con yourself that because you didn't see anything that you couldn't have an allergy or...
That's right.
Yeah,
it's not a guarantee.
Couldn't play at being immunologist when we don't know what the fuck we're doing with a patch test, I guess is what I'm trying to say.
Yeah, that's right. Well, if there's any question, you just, you can pre-medicate it with prednisolone.
Yeah. So, I mean, we've sort of spoken about many, many things, but just to sort of summarize, where should we go from here? What's the future of managing complications? What's your advice to people about potentially learning ultrasound? Like, where do we go from here?
I think if you are interested in learning ultrasound, focus on a few areas that you will use it, and you can integrate those few areas in practice, and then just add it on slowly. And if you are determined, like Stephen Weiner, who's in the CMAC group, he scanned himself during COVID and just looked at all the structures and just practiced and practiced and practiced. I think there's an ultrasound facial anatomy book that's out too. I think he might have written it. So that would be useful as well. But just stick to a few areas where you can use it first and just do that. Like, say it's chins, just stick with that for a while and just get used to it. But also, if you're determined enough, scan your friends, scan yourself, sit in front of the mirror or sit in front of the scanner and just, you've got a face, everyone's got a face, right? Scan your face, just keep looking at it. Look at the frontalis muscle, look at the fascial planes, look at what subcutaneous fat looks like, look what deep subcutaneous fat deep to the SMAS looks like. So just scan your own face and just keep going and going. You will only get as much knowledge possible, not through a teacher, but through yourself.
Yeah.
You have to be determined and you got to study. Like when we have a fellowship and they're studying MRI, I always say to them, you will get as much as you want out of this fellowship only through your own study, your own research, and looking at cases and learning about those cases. You could make this fellowship useless because we're not going to teach it all to you.
Yeah. If you want to have a real life, scan your kids. They love it. Done it with my kids. Get your iPad out and talk to them about
and start scanning.
X-ray. Yeah. They love it. It's fun. And
cool.
They've got decent superficial fat and, their faces are round. So you really get to understand what fat looks like. Cool. Yeah, it's interesting.
Scan your dog,
Yeah, exactly.
You probably needed to scan your dog today.
Yeah. Yes. My dog had a little...
I reckon if you scanned it, you would have probably been able to do it all yourself.
Well, yeah, but I don't want him biting me by lancing the abscess.
Well, it's also not that. It's also the probe goes on people's faces and you would have put it on the dog's.
Correct. Well, it was so obvious. It was this big pointing abscess. So it couldn't have been anything else. But
yeah.
Anyways, let's leave that to the vet. I'm not going to go stabbing my dog at home. And I need one of those big collar things to stop him licking it after. So
you've got the big cone.
Yeah, exactly.
Looks very cute.
Poor little thing's got one of those. All right, let's final question. What are your top tips to help avoid a VO? What should injectors be not doing in their clinic?
Right.
They might have been doing.
So when you go to a conference, don't follow the trend straight away, because what happens is the VOs become a trend, right? So what I've noticed is more frontal branch of the superficial temporal artery, occlusions, since this superficial technique in the temples.
Interesting. Okay.
I feel personally, if you're blind, you're better off with the one. You're still better off with the one shot. If you've got an ultrasound scanner, get the probe where you're going to shoot, put the color on, just look for a little pumping thing in that temporalis muscle deep. If it's huge, don't touch it. If you can't see it, just be very careful. Make sure you're sure that you can't see it, because if you miss it and you stick it, that's bad. But I see more superficial occlusions than I've never seen a deep one, actually, to be honest. Not one. From a temple one-shot technique. Your chins keep midline. Do not swing even a millimeter to one side or another if you're doing blind injections. And this is for vascular occlusions. And also, as soon as you decide in an area you don't want to use a cannula where you usually use a cannula, you'll get yourself in trouble. Like on a Friday afternoon, you want to get home.
What would be a common area where people make that decision?
What's that?
What would be a common area where people make that decision?
Jawline.
All right, jawline, yeah, fair.
Lateral jaw. This area is also the second common and that I've seen. The most common has been the chin area, submental or labiomental artery. Second most common up until recently was superficial temples, and then the third was actually bottom and top lip.
Right.
Inferior superior labial artery.
Well, stay safe out there, people. Listen to what Mobin said. Consider learning ultrasound. Inject slow, small boluses. Keep your needle moving. Use can. Just do everything
wherever you can. And don't rush it, man. Do not rush it. There is no rush. Take your time. Know the plane. And when your gut tells you, I probably shouldn't do this, don't do it.
Yeah, listen to your sixth sense. It served me well many a time.
Yeah.
Well, thanks for coming back on, bud. It's just good to sort of rehash where we are at, and has anything radically changed? I don't think so. We're moving in the right direction.
Yeah.
Cool new toys.
Yeah, I love these technical ones. Got to get to sit here and listen. It's good.
I think we've learned a bit more about what's happening around the eyes, I reckon.
Actually, one thing that I didn't mention on my Clarius is, the handheld one that, it's not as fancy as yours, Mobin. David was saying, what can we do to sort of make it dumb down? It's got now a new, I don't know what they call it. It's like a color filter, and it will show you the basic layers of certain areas like the temple. It will say that's muscle, that's fat.
That's it. That's cool. Yeah.
It's pretty.
That's awesome.
It's not perfect, but at least for someone learning ultrasound, forget injecting, show them the grey thing first, and sort of with first principles try and work out what you think it is, and then throw the colour thing on and test yourself. It's kind of a
exactly
thing that you can do. So there you go. It is getting better.
Whatever work.
Yeah. All right, buddy. Well, hopefully we'll see you soon. Are you coming down to Sydney for anything special?
No plans. It's pretty hard, as you know, to travel at the moment, but I'm in a good position now. I'm solo for 3 weeks. The family's gone to the in-laws to Adelaide.
Very nice.
Yeah. So the studio is going to get a bit of action.
Okay, fair enough. Let's plug this. I know you've got a new single out, haven't you? Let's plug your new single.
It hasn't come out yet.
I saw you talking about it somewhere.
Called in the Club, Mobin Master in the Club, and it's a rework of the old track that says Monday night, 2 the club, Tuesday night, 2 the club, Wednesday night, what a headache. But
when is it out, and how can people listen?
It's all going to be on Spotify. If you search Mobin Master, you can find me on Spotify. It'll be out in a couple of weeks.
Cool.
Excellent.
Yeah, we didn't tell people who people who've not come across you. You had a massive hit many years ago.
Show Me Love.
Yeah, it is. Show Me Love, yeah. So, great song. Check it out.
Yeah, check it out. You're
a doctor now. That's your old life.
Yeah. Oh, no, I'm still gigging and I'm still producing. It's a passion. It's great, and that's part of the reason why I got into the industry. It's still, especially when you're injecting, not dissolving. There's an artistic side to this, and it's more artistic than medicine. It's not all protocol. Yeah. You can use a bit of art. You can use your visuals. That's what I love about it.
Yeah, fantastic. Right, buddy. Well, thanks for your time again, and we'll speak soon.
Thanks, boys. We'll be in touch.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.